Welcome to the Telecom Exchange CEO Roundtables, both for our guests here at Telecom Exchange NYC and for our viewers who are joining us from RCR TV and JSA TV. Thank you. Our third panel today is on the hot topic of telemedicine. It's the telemedicine revolution, big data, IoT, and 5G leading the way. And we are very honored to have Larry Walsh, the CEO of the 2112 Group, a seasoned journalist, analyst, author, and industry commentator. Larry is also the founder of Channelnomics, which is a leading provider of IT channel news and analysis. A specialist in the development and execution of channel programs, disruptive sales models, and growth strategies for companies of all sizes, from startups to Fortune 500s. Larry's worked with a roster of diverse technology players, including Ingram Micro, Intel Security, SAP, and Verizon right here on our panel. So go ahead and welcome Larry Walsh. Larry?
Thank you, Jamie. Afternoon, everyone. I just want to start by talking about why we're having this conversation today. And I tend to, as Jamie says, what my company and I do is strategy. We look at the world around us and we try to imagine how to make it different and then try to bring routes to market to it, or apply routes to market to it. And lately, the questions that we've been getting have been around, how's the world going to look in the future? Well, it's not really a silly question. We're already living in it. We were just having, the panelists and I were just having a conversation about video phones that were introduced in the 60s that, didn't really work, but now we have them for free. When we start talking about telemedicine, the conversation gets vastly different. And it's not because of the technology, it's about demographics. So by 2045, we will have worldwide 441 cities with more than 1 million people in population. Imagine that, because it's truly, the globe is urbanizing, and it's urbanizing rapidly. And many of the cities that we're talking about are urban centers that we've never heard of. Combine that with what is happening in terms of life expectancy. So currently, the average life expectancy is 71 years globally. If you're lucky enough to live in a more developed country, like we are, the life expectancy is about 85. Now, fortunately for women, it's a little bit higher, so you get a little bit of peace from us. But it does start to exasperate the healthcare industry and the healthcare capacity. Because with that life expectancy, what's happening simultaneously, even though you see this urbanization, this migration towards urban centers, we're also seeing a declining birth rate. So most of the Western and developed countries are actually in negative population growth. The United States, just for instance, the United States is on the cusp of going into a negative population growth. Other countries, Japan, Germany, Italy, are all in decline in terms of population. The Japanese are investing heavily in robotics, not for the industrial and manufacturing capacity, but to care for their elderly. So when we start talking about things like telemedicine and automation in healthcare, it's not necessarily about applying technology because we can. It's because we're doing it out of necessity. We simply do not have the manpower to care for the people, particularly if you think about it. We spend today $6.5 trillion globally on healthcare. And most of that spend is on the last 2 years of life. So when we start looking at the demographic trends, and we start looking at the cost, and we start looking at the decline in talent, if you just look across North America and Europe, we're importing healthcare providers because we simply cannot grow enough fast enough domestically. So telemedicine is really about applying our resources in such a way that we can gain the economies of scale and provide a quality of life for the population, and to augment the limited resources that we have. A lot of this is, as Jamie said, is coming about because we are in a position to where technology has caught up with our imagination. And if you hear me talk about, in other venues, you'll hear me talk about that our imagination is actually outpacing our ability to deliver. But we are actually at the intersection of where these mega trends in technology of big data and high-speed ubiquitous networks are converging to allow us, to give us the capacity and the ability to deliver technology in ways that we thought weren't possible before. So that's what we're going to talk about today. We're going to talk about the evolution of the telecom infrastructure, the ability to pass data across wide areas around the world, and to be able to apply technologies from mobile devices, cloud computing, big data, and automation to improve quality of life and to deliver healthcare in places where where it hasn't been available before. So we have a great panel here, and I want to start with Brian Prophet of AdTel. Brian, why don't you tell us just a little bit about yourself, and also why don't you tell us about, if you have a telemedicine or a remote health experience?
Sure. So again, Brian Prophet from AdTel. I've spent 18 years in the industry, primarily in a role working for carriers, but in an advocacy role working with Internet 2, National Lambda Rail, NIH, NASA, NOAA, working through being able to be the advocate to the carriers to be able to partner on these advanced research networks for healthcare, for education, for research. Personally, I ditched the Fitbit about a year ago. From that standpoint, I found there was very few places that I was not carrying my phone. So I thought letting an app do that was a little easier from actually wearing one more device.
Very good. Next on the panel, Felipe Alvarez, the CEO of Axiom Fiber Networks. Felipe?
Hi, Felipe Alvarez, CEO of Axiom Fiber Networks. We're a provider of high-capacity infrastructure services in New York. My experience in healthcare is really tied to being that fiber provider that connects sites, primarily data centers, high-end, very high-end things. So my interest in this panel is really, what's happening with the evolution of taking broadband essentially to the rest, in many cases, and how that impacts delivery of services, basically. So it moves to what I read about, which is instead of the IoT is the IOP, which is the Internet of Patients, right?
I'm going to steal that one.
That's good.
All right, next, Cliff Kane, the co-CEO of Clarion Fiber Networks. Cliff?
Yeah, hi. Cliff Kane, co-CEO of Clarion Fiber Networks. We are a New York area telecommunications services provider, primarily focused on the wholesale community. We sell to carriers, but we are extending that into the enterprise space. I have no, I've been thinking about it. I don't have any device that is, I don't use Fitbit or anything like that to carry a phone with no apps that monitor my health. I guess I feel I'm healthy enough. But our interest here is because we have been strong proponents of what's happening on the edge, especially in light of 5G and IoT coming on board. And what is the infrastructure going to have to look like to support that? And telemedicine, is a lot of different applications within telemedicine. But if you look at it holistically, a lot of that's going to all happen on the edge, and it's going to be about how you transport that data back and forth to storage, to different physicians to get diagnosis and the like. So the edge is, of critical importance to us, and I think that supports the whole telemedicine infrastructure.
Okay, next, Drew Mullen, the Senior Vice President of Business Development and Strategy at Light Tower Fiber Networks. Drew?
Yeah, I do not have a Fitbit either, so I think that we're going to take down the average age on this panel there. My name is Drew Mullen. I'm the SVP of Business Development and Strategy for Light Tower Fiber Networks. So we build and operate fiber networks across the East Coast, and we've got about 33,000 route miles of network that we offer up. This morning someone talked about trying to predict how much bandwidth, is going to be coming from Internet of Things or telemedicine. I'm a fiber guy, so I don't care what the thing, we can just throw more fiber at it, and that's the answer for a fiber guy always. Telemedicine here, I'm excited about this because I think telemedicine is very personal. personal for everybody in this room. Just a quick little thing about me. My wife is a pediatrician, and my father-in-law is an orthopedic surgeon. So in preparation for this, my wife doesn't know anything about fiber, but she actually gave me some things about how she does what she does and how the telecommunications in the fiber world are solving those problems. So this past weekend, I was at a softball tournament with my 17-year-old daughter, and she's a catcher, which if you've got kids, never have them be a catcher. But so my daughter was catching, and a girl came up to the plate. She was really large, and she had a really long swing, and she wound up catching my daughter on her hand as she was doing that. So meanwhile, we immediately go to the emergency room or whatever. She gets her hand scanned. We're there for about 8 hours, and finally they came back and they said, okay, you're good to go. And we said, what took so long for this? And they said, well, the person that needed to read the scan wasn't here. They were actually on break, and then they got, involved with other stuff. And I said, really? And they said, yeah, this probably should have taken an hour for you to get in and out of here. And I said, just because that one person wasn't there. And I thought, here's a really practical way. And that sort of affected me, and I'm sure everyone here has kids or a parent or something else that telemedicine is going to affect you. So, that's sort of my personal most recent story. So I'm looking forward to the discussion.
Good. And last but not least, of course, Nancy Green, the Global Healthcare Business Development and Strategy Executive Leader from Verizon.
Hi, so I come at this from a completely different lens than all this. I live telemedicine and work within telemedicine probably for the last 15 years. I've been in healthcare for 25 years around the technology, not a clinician. So, so in the role that I have with, if you think about Verizon, most people go, what in the world are they doing in the healthcare space? So to kind of set the stage, I'm one of 5 vertical leads. So I lead healthcare, there's another one for media entertainment, insurance, or I take insurance now, there's energy, utilities, things like that. So they pulled from the industry to say, how can we use all of the size and scope and scale that Verizon has to apply to a vertical's business problem? So telemedicine has been a healthcare business problem for a very long time. And it's not a technology problem. It is a workflow problem, which you just identified, and an interoperability problem, period. And as we go further, I can talk more about that. But it's not about the technology. There is an age thing with physicians who want to use it and who doesn't. But I would probably ask, how many of you have ever done a virtual visit, a video call with your physician? 3, 4. Every one of the insurance carriers offers this as a service to keep you out of the emergency rooms, and no one uses it. So it is there. It has to do with how the business problem is looked at by the industry. If I'm a payer or a provider world, it's vastly different, and who's paying for it. So it's just now in the last couple of years gotten to be reimbursed. So this whole telemedicine covers a huge area, lots of different ways to operate. It's not just video. It is just the movement of information back and forth.
Yeah, right. All right. So as Jamie said, this is a roundtable. It's not a panel discussion. So let's be a little non-traditional. If you have a question and you want to get involved in the conversation, which I encourage you to do, I have a bunch of questions here, and I'm not afraid to use them. But it would be far better if we all participated in this, because it's going to touch all of us at some point or another. But I want to come back to, and Nancy, I was going to start with you with one of the prepared questions, but I think you just said something very interesting. This isn't new. We've been talking about telemedicine and remote healthcare delivery for the better part of a decade. I remember, I think it was 10 years ago, Cisco showing off using their telepresence technology to do remote examinations in clinics. So why isn't it? Why isn't it more prevalent?
Probably 2 things. The biggest has to do with reimbursement. It wasn't reimbursed for a very long time. Certain states didn't reimburse you, like Texas finally just passed. I live in Dallas. Finally just passed that you didn't have to see a doctor first before you did a telemedicine visit. So then the payers weren't paying for it, or they would pay $25 where if you went to the doctor, he'd get $100. So the doctor didn't particularly want to do it. So the reimbursement is happening. It's getting there. It's not fixed, but it's getting there. And I think if you look at it from the push of how the industry works, if you look at the 4 or 5 main areas in healthcare, they're trying to increase the access to care while improving the quality of care. So, and I always use this in New York City because you probably don't know this. Within the New York City area, the 5 boroughs, there are 6 areas that are considered federally underserved by physicians. It is not a rural problem. So physicians go where they want to live, not necessarily where the patients are. We have cases of cities who pay for doctors to go to school and to just operate in that area. So they're trying to lower cost, increase access to care, increase quality of care. But now the entire focus is on patient experience and clinician experience. And the clinician experience almost overrides a little bit of the patient experience. So as the clinicians start to put it into their workflow, it gets part of their business. You got to understand, if you asked your father-in-law, he's done the same thing the same way since he went to med school. And you introduce a telemedicine, you have to introduce it into that workflow. And they are probably, 100-plus-year-old system of doing it the same way. Mm-hmm. And so it's difficult. And so when someone puts together a program to interconnect and have a virtual visit in your rounding, we've had hospitals who have put together a room in a hospital because they round in a floor. They put a room in there that's a video room. And so he goes and grabs the chart, goes into, so just to get it part of the flow.
Okay.
Right?
So, yeah, other than...
If I could add to this, because from a the tele component of medicine, telemedicine, not only the technology advances, but the penetration of readily available, reliable broadband, right, has increased dramatically over the last, I got to say, it goes up every year, but certainly the last 10 years, especially on the wireless side. You have gotten advances that allow a lot of that information to happen with enough sufficient latency and clarity and so on and so forth that you can actually...
technology problem.
Right, because so it's not a delivery, you need a fiber pair into the physician's office. Ideally, yeah, you would, but you don't have to anymore. Yeah. So some of that drives adoption of better economics, because think about the premiums. I mean, what happens when you start leveraging technology to do that remote diagnostics, remote testing, remote visits and things like that.
The information from it is more important than the actual interception. So if you're doing a video consultation, the doctor can do a lot of what he or she's normally used to doing. If you're moving data from remote monitoring equipment, anything that's in a hospital or at home, that's just pieces of data that is overwhelming to the medical community. They want it put in context. So once it's put in context and the smarts are put around it, it makes it usable data and actionable for them to make a better health decision for you. Otherwise, it's just data. So to answer your question, it's been so long that it's just a lot of data, which is how many people have stopped wearing the Fitbit. Most doctors don't care if you walk unless he's an orthopedic surgeon. He cares when he put a brand new hip in you, are you taking 10,000 steps a day? But so it's that whole data just went, okay, here, doctor, here's all my stuff. And he's like, that's nice, thanks. So now it's starting to get like, if I can get context around it, I'm good.
Yeah. I'm still trying to figure out who said 10,000 steps was the right level.
I still don't know that either.
So I'm just going to throw this out to the panel, because before we get up to the application layer of all this, because a lot of great magic can happen up there, and Phil, you said it, is that we have the infrastructure for it. Is it the long haul infrastructure that we have, and is the last mile there? Or are we looking at that we have enough infrastructure to support a true saturation of the market with, that have ubiquitous use of telemedicine? So I'll let everybody answer on this.
Well, I'll take a shot at that.
Please,
I think it's location specific. You could be someplace where the doctors may have good infrastructure to support telemedicine and some high bandwidth applications, but the patients that are using that those doctors are trying to diagnose may be some places that aren't. One potential remedy for that would be to create centers where the patients could basically come in and you could have the broadband connectivity and telepresence that you need to conduct a good diagnosis. But I think it's the same story as broadband across the country. It's really very location specific. You have thousands of buildings in New York City that don't even have fiber in them. I mean, that's commercial buildings. So that as one perspective on that, it's just, I think it depends on where you are.
Yeah, and to add to that, I mean, from Light Tower's perspective, healthcare continues to grow. I mean, we've been in the space for 15 years now, and every year we're amazed at how much more bandwidth these hospitals are using and finding ways to do it. So whether they have dark fiber or gig E or 100 gig, they continue. It's like closet space. As soon as you have it, you need a little bit more. And so about 10% of our revenues are healthcare related and continues to grow.
Yeah, and
Go ahead.
Brian, please.
thank you. And I think one of the things to keep in mind too, the core backbone is not the issue. The big shiny hospital buildings are not the ones that have problems getting the connectivity to them. The business model works there to get fiber to them, and if the carriers won't do it, it's easy enough, whether in a large city or the second and third tier markets, for the carriers, the hospitals, to justify building out fiber rings themselves if they can't get it through wholesale available fiber. I think what you have to start looking at is getting, as we talked about, getting closer to the edge. When you go to that clinic for the emergency center, and these emergency centers are popping up everywhere because pushing healthcare to the edge is the same as pushing data to the edge. When you start looking at it from a standpoint of bringing these things to the edge, being able to have an X-ray machine, X-ray the hand at the the clinic near the baseball field. If there's somebody in a data center type environment, of radiologists that are able to read that and provide real-time feedback. This is how you start having remote care. This is how you start bringing that to the edge. And when you start looking at, is it a last mile or a backbone issue, I think you have to start looking at, to justify that, it's not just the backbone to the hospitals. You have to start looking at the ecosystem of healthcare in the communities, to the doctor's offices, to the labs, and that creates opportunity to justify some of that metro expansion when you start looking at, kind of the schools, the hospitals, the libraries, again, as an ecosystem in a neighborhood.
So
Please, Nancy.
the tenet of that driver of increasing access to care means that they have to what he just said, they have to push care as far out as they can, which then gets into the problems of how do we get information there, how do we communicate back. And that's in a clinical environment, to your point, or whoever said it, to go to a center to be able to do that. The bigger driver is this whole consumerism model, is that I don't want to go somewhere. I should be able to do it off my phone. I do everything else off my phone. And that's driven them to change their business model and come up into a very competitive world. So some of the very unique solutions that you have can have you compete in a marketplace. So an MSK or Sloan Kettering can compete with someone here in the local market that is doing the same thing, but being able to offer some type of service that allows them to do something unique, because they're now, as a consumer, think of yourself as a consumer, you've done your research, you're not really loyal to your brand, right? I'm trying to think of my New York hospital, sorry. You're not typically loyal to just that brand. You can go to whoever you want to, so whoever is advertising the best, or whoever has the best ranking, whatever that is, you're going to go that way. And so this whole piece of being able to offer services that are unique in their specialties is something that's pushing them because of the consumer side of the business.
What's driving the adoption, though? Is it a capacity issue that the clinicians, the hospitals, the physicians' offices or practices are coming in saying that we need to scale more, we need to connect to these resources? Is the regulatory climate changing, where the government is coming in saying that we have to automate and we have to do more sharing? What's the driver behind the trend?
I think it's money. I mean, at the end of the day, if you look at where most of our healthcare is at and where the biggest expense is going to be in the next decade of Medicare and Medicaid, you've got to look at how the payers will look at telemedicine. There's three categories that they look at, and that you start looking at real-time, interactive visits. You start looking at, store and process of data, and then you start looking at remote monitoring. Those are the three reimbursable categories. The problem has been really just as an adoption happens. To Nancy's point, for a very long time, over the past decade or so, as the technology stopped being the problem, it really became a process of the only thing that was coverable was real-time interactive. You had to be looking at the doctor and working with them. It couldn't be the step in between. It couldn't be a remote call center full of radiologists reading x-rays and providing that feedback back. That wasn't a reimbursable expense, because that wasn't the radiologist didn't walk in and go, okay, this looks great, and the doctor didn't come in and look at the x-ray to look at the report that the radiologist gave them to say, yep, it's broken, or no, it's not. That's a monetary decision.
The only thing I'd add, I'd agree with Brian that it is a monetary decision, but I mean, the quality of the care that you also get from that is a key benefit. And I think, in a healthcare environment, doctors don't discount the fact that they're trying to give the best care, to their patients. Always. So, certainly there's the monetary aspect where it's more efficient, but I think that it's also just better quality of care. My wife does the newborn nursery, so when she has to discharge a child, she has her smartphone there, and she gets these, bilirubin tests, and she has literally a thing that pops up on her phone that this test got back. Should I discharge this, this baby or not? And, in the old times, you wouldn't get that, and you might be in the hospital for another 5-6 hours before the doctor sees it. Now she hits the dope, okay, bilirubin's good, off the baby goes. So that family's happier with the care that they got too. And, it was probably more cost efficient too.
Well, and it's about that real-time information, to Drew's point. I mean, it's, pre-telecom, the first 10 years of my life, I was an EMT and, did that professionally. And I think there's a lot of the time where it's that real-time information. It's triage, right? If they say that my hand's broken, if they said your daughter's hand was broken, it doesn't mean you're not going to follow up with a proper orthopedic surgeon for the proper level of care. But being able to make a decision, in 30 minutes, we took the x-ray, we had a picture, we knew there was a fracture. Now I know what to do next. You're cut 8 hours of time and management and interaction from that experience of that care to the person, to the consumer, to the point. This is really what it starts looking at from a consumerism of healthcare.
Yeah, I think if you talk about adoption, and I'm thinking as people were talking, it's really around, in healthcare we call them service lines. So ED is a service line, dermatology is a service line, that kind of stuff. So cardiology is a service line. So they're use case driven, and some have better adoption than others. So the radiology example happened 10 years ago because it didn't get paid for. It just was ease of use. And all your radiology went overseas. They looked at it, sent it back, and you didn't even know it, right? So as you start to see some of the use cases that are the subspecialties, especially in behavioral health, or some of the surgeons, or some of the neurosurgeons, they're such a subspecialty, which means there's not very many of them. That's where the adoption is super high. And in some cases, they need really high bandwidth because they're looking at all kinds of things to help diagnose or help another patient globally, not a patient, another physician. So for many years, it was physician to physician because it didn't matter, right? Because they got paid for that. That's a consultation. They got paid for it. So they used a lot of that. And then as they started to get down, okay, I don't need all of that to be able to do it over the phone. I don't have to go home to look at this, that kind of stuff. So it really has to do with the use case and the center that you're part of and their view of it. If you are part of the Cleveland Clinic, you have a very different view because of the management of it than a smaller facility in South Carolina that might not quite be worried about that yet because they're just trying to take care of their community.
And to Nancy's point, having worked with the internet too and the research community, the top research doctors, those hospitals, those facilities, the university medical centers, they have the connectivity that they need. Again, it's getting that connectivity out to the doctor in that that remote South Carolina hospital.
So, please go back.
Oh, sorry. As far as security, and this is for Nancy, my wife is a nurse practitioner as well, and the HIPAA laws are very stringent. Is there anything inside of HIPAA that basically forces a network to be secure, to protect that data? And is that maybe a reason why people aren't using it?
I don't think it's so HIPAA is you've all signed it every time you go to a doctor, right? It's really the sharing of your personal information wherever it should be. So the HIPAA regulations are purposely void, and every lawyer in the world has said this is how you should look at it. But it's really about the protected health information, or PHI. So if the data coming back and forth has no consideration of that's Nancy Green's information, it's not under the HIPAA regulations. If you're just transmitting and you're not storing. So a virtual video, you don't have to go by HIPAA laws because you're not storing the video. The minute, as a service provider, the minute you store something, then now that data center has to be secure, all of that kind of stuff. The transport piece, Verizon or any fiber, there's a transport exception in the HIPAA laws because you're just transporting, right? But the minute you start to touch it, look at it, manipulate it, then the HIPAA laws start to come through. So data centers have to be HIPAA compliant. The person that will get the fine will be the hospital system. They are the covered entity. And you, by business associate agreement, will get pulled into that lawsuit.
But
I don't think it stopped adoption because of that. The security piece of it is everyone's super worried about that.
so
But
the,
if I may, because
Please,
it's
Phil.
security and thinking about security, I mean, there's multiple levels. But
Yes.
as you go to adopting wireless, and this device becomes more potent in terms of healthcare potential capabilities, you're transmitting all this stuff wirelessly.
Right.
And when you think about a generation of people that grow up just like I'm old enough not to be digital. I learned to be digital. My kids are digital. They were born with that, essentially, gene in their in them, right? So they would expect this or some similar device to actually do a lot of the things so they don't have to go to the doctor. I mean, if I don't have to go to the doctor, if I could do it through this, I would do it gladly.
That's why
because
it's
I don't wanna do
important
that.
when you're making those that nothing resides on the device. And so we do a lot of that consultation is don't have anything reside on the device. Everything's in the cloud or remote. So it is a use as a transport piece, but you know.
But once you go wireless, it makes it a lot easier to grab that data off the air, I think, than if you have a physical connectivity.
so as a
It's
covered
roaming, essentially.
As a covered entity, though, trying to comply with HIPAA, one of the pieces of due diligence would be to encrypt everything.
Yep,
And
absolutely.
encryption does come with a bandwidth tax. So does the infrastructure have the capacity of handling totally encrypted traffic?
Yes.
Cliff?
Well, it can and does, depends on where and how. But what I was thinking about while this conversation was going on was, as you know, telemedicine expands and over the future. I mean, how are you going to keep these? How are you going to keep this fluid and keep these records private? And I think actually blockchain is going to play a huge role coming into that into focus in the next few years, as it will with many other sectors. But I think the ability to keep it fluid is key, right? So you wanted to have the patient and the doctor interacting, on a real-time basis, and how do you do that on a scale that's massive? Again, I would say it goes back to the edge, and then I think one of the ways to keep all those records safe is by using blockchain as the storage and forward technology.
Okay. So we have a question back here? Please.
So far, a lot of the conversation has been geared around kind of the patient-provider experience. And I don't know if we're going to segue, but my question is more around kind of big data and IoT. And how are hospitals kind of adapting to IoT? How are they using it? And how are they adapting to managing the large data sets that come from it? And how does that affect the folks who's caring?
It's a good question because, the question, just to repeat for those that didn't hear, is what is the impact of the adoption rate of IoT within clinical settings, and what's the impact on the infrastructure?
I would ask how you define IoT first.
Smart devices that are pulling back data to some central point, and hopefully organizations utilizing that data.
So clinical smart devices or non-clinical?
Yeah, clinical.
Clinical. I was just clarifying for the group, sorry.
So it does, I mean...
Makes a difference.
Well, look, just look at it as healthcare devices, whether clinical or non-clinical, that, there's going to be a number of non-clinical devices that are going to be feeding healthcare information into clinical devices or clinical systems that will get aggregated up into big data. So if you look at that as a derivative of the 20 to 50 billion IP-enabled devices that are going to be online in the next 5 to 7 years, it's a huge amount. These IoT devices are huge just packet generators.
Yeah, so I think first the reason I asked is that when clinical has to go through the FDA if it touches a patient, right? So they're very regulated. So you can't just add something to a clinical device. You have to go back through everything. So if you're going to add and we work with all the major manufacturers on devices. Every Philips Respironics device for sleep apnea, there's several million of them, all have a little chip on them that sends information back to Philips that says where it is, did you use it, what it is, and they're sending that information to your physician. So it's use-based, so lots of clinical stuff is done. Non-clinical, it's kind of, I call it the Wild West. You can do lots of stuff with it, but it doesn't matter if the information doesn't make sense or give context to someone else. So the question in IoT, and I was on the IoT panel earlier, we talked about, in healthcare, it's a lot around asset tracking and what's called cold chain, which is temperature. So is the blood bank correct? Are the pharmaceuticals being kept at a certain temperature? In the pharma space itself, it's globally tracking the drugs so that it's the right drug as it goes through. There's no counterfeit drugs, things like that. And so that's their IoT world in that space, is really looking at how do I take all of this information. The hospital systems run on their electronic health records, and the electronic health records don't have fields for a lot of this data. So physician, none of that data is in there, and there's only trusted data in there, and they don't trust anything else that they don't know a person touched. So it makes a difference in, like your Fitbit, if it goes directly in, it goes, so there's some heart monitors that you can actually adjust the numbers. They don't trust that data, so they don't even look at it.
Yeah.
So why is there no trust in the data?
I'm sorry?
Why is there no trust?
Not
If they're a physician, they can make a bad medical decision and be sued on data that they don't trust.
So to elaborate on this, Nancy was on a panel this morning. She talked about how the healthcare industry has been somewhat slow in getting to the technology, which I couldn't agree with more. I think it's part of this is generational. I hope my father-in-law is not watching this ever, but because we were dragging through the mud. But certainly there's a certain number of physicians out there that just aren't comfortable with technology, and they're going to be retiring, and you have a whole nother generation who are more comfortable with it. They're going to be using it. In addition to that, these hospitals, I think, are realizing in order to be competitive and give the level of care that is required, and it is competitive, then they need to do the work with the Internet of Things, and they need to work with technology, and they're actually having positions, where they have someone in their hospital, and that's their job, is to work with departments. And there's a huge success factor when hospitals do that versus just saying, oh, we'll let each department roll it out themselves. That doesn't work as well. So you need somebody to be the champion within your hospital for all these types of things. And it's going to be a process that we can continue to go forward.
Yeah, and I think people in the room, I've heard a lot of data center conversations. Most hospitals their data centers don't have any of their patient information in it. What they're storing is non-clinical patient information because they don't trust it. Right? They don't trust anybody coming out of it. The breaches that happen in healthcare are not into that system. There's someone's lost laptop or an insider doing damage. So, as you look at the data centers, that's why you're getting so much fiber into a building. It's their own center, their own stuff. And what they offload is storage or non-clinical applications.
Do we have another question in the back?
Oh, well, I was just going to, and now that you brought that up, so where do they store the clinical?
On-site, they have their own data centers on-site. They manage.
Okay, because kind of along the lines of the telehealth. I broke my ankle, and luckily, my husband was able, they told me I had to have surgery that night. Luckily, my husband was able to call a friend who was a radiologist somewhere else. He tapped into it within 5 minutes and saw my x-ray. And he was completely somewhere else. How was he able to do that?
So a couple of things. He had rights to do that. So he couldn't have gotten into that hospital system without rights to get into the access it. So he was already connected. He already had rights. So physicians have rights into different facilities. Most physicians have multiple facilities that they work out of, and they have rights to do that, and they have a login to get it. That's very secure in how they do that. That's what the biggest complaint is, because it times out after like 10 seconds, and they have to re-log in again. So that's probably one of their biggest issues.
It just seems like, having second opinions, whenever you're doing something major or whatever, being able to access somebody remotely quickly would be, and it's just where the roadblocks to all of that.
Yeah, I think I always say this, and if there was some money in it, I would do it. You have to be your own advocate as a patient. You just absolutely have to question. Just like it's like, why is it taking so long, or what else can I do? If you run under the premise and understand that the healthcare industries, well, I should say health providers. When you talk about healthcare, there's also payers. But the providers think they own your information, which is why they don't let anybody look at it. It's your information. It's not theirs. So there's always this kind of butt up against who owns the information and where it goes. So.
All right, so we have time for a couple more questions. Let's go down front here.
Yeah, in starting of the discussion, talking about the supply crisis that is ahead of us, and a lot of what was discussed was around either better matching demand and supply in terms of locations, or in terms of improving the patient journey or patient experience. But is telemedicine actually able to increase the supply in any way? And to elaborate on this, because telemedicine is in a way a slightly inferior experience in terms of delivery, might be, won't it actually generate a decrease in supply because the process will have to be redone multiple times? So for every number of telemedicine visits, the patient will actually have to see the doctor himself.
Oh,
There's already studies that have proved it's actually more effective.
I was going to say, how many times do you have something where you're sick? The patient experience, will increase the supply because you'll be more willing to interact with your healthcare provider. I had a surgery and I had to have, something checked out. I could have waited a week to go to the doctor, but I called him up and I knew he had an iPhone and I said, look, I know this is out of the practice, but I'd rather not come to the ER on a Sunday night at 9 o'clock just to check this incision site. Can you look at it? Right? And then the education was, well, I can't do that because of HIPAA, right? And I said, no, this is real time. There's no records, there's no storage, there's no nothing. That advocacy, that understanding of that patient experience will make you not reluctant to engage with your healthcare provider, to not be part of the healthcare system. It's something that you avoid, like going to the dentist, right? I mean, if I could have my tooth checked without having to get it drilled, that'd be great. But from a regular health involvement, if I knew it wasn't going to take 8 hours to get somebody to look at this, I don't think it's broken. Right? EMT for 10 years. I don't think this is broken, but it's my daughter. I'm going to have them check it out. It's probably not, but I know that's 8 hours of my day gone. Yeah, if it's my hand, I'm going to wait till tomorrow morning and make an appointment.
So actually, that will increase the demand for the service.
Absolutely.
But is telemedicine able to increase the supply?
Yeah.
So Larry started off speaking about the supply being an issue. So basically, is telemedicine able to make physicians significantly more efficient?
I don't know about significantly more efficient. So the supply of physicians is going down, the same with nursing. So they have to become more efficient. And we're always advocating for them teaching in medical school how to be a technologist as well as a healthcare provider so that they learn that. But the interaction between a patient and a physician, you have to remember, they cannot diagnose over telemedicine. So, they can do follow-ups, they can see you initially, but they're going to say, hang up, go to the ER right now. Because they can instantly tell what's going on. So the challenge, to your point, I think we kind of touched on it a little bit earlier, the challenge is to help those physicians become enabled to do more visits. So if you think about, you only get 5 or 10 minutes and you waited 4 hours to see him or her, that's because they're backed up and because they're scheduling too much. So their problem is always, well, I got to start my day an hour early so I can see 2 more patients. So virtual video under telemedicine is very quick. So they can actually see 10 or 12 patients in that same time that they probably only saw 2 or 3 patients. So, but some physicians won't do it, and that's just the way they are.
All right, one more question.
So 2 questions. Where does the crux lie? I mean, I can understand the liability aspect, but that's based upon the sensor data, essentially, from remote diagnostics. So where is the crux within that in order to make it viable that you can have remote diagnostics through telemedicine? The second question is, there's just a big movement for disaggregation away from big hospitals and move to clinics and that sort of stuff. And some states have started to take policies around fines, or insurance companies as well, fines around situations where somebody goes to the ER for a non-emergency setting. Are those sorts of monetary funding kind of penalties going to drive more telemedicine as well?
The carrot and the stick work sometimes, but that's the carrot and the stick to the patient, not the clinician. So the patient pays more when they go to the emergency room rather than going and waiting the next time or using virtual visit. That's a training issue on making sure that the payer communicates that. I think your first question, when you look at remote patient monitoring is monitoring biometrics So, weight scale, blood pressure, pulse ox, those kinds of things. That's information that a physician can use to help make a diagnosis or help prevent something. So your blood pressure went up in 3 days. It shouldn't have been. You're now red. Nurse calls you. What happened? What'd you do? Because you're a CHF patient. So it's more preventative than anything else. And for a long time, payers didn't pay for that. Because if you think about it, and I don't normally do this if we have time, your lifespan at a payer is short. So your lifespan at your employer is longer traditionally than it is at your payer. So think about it. How many times have you changed payers in your jobs or whatever, right? So for them, unfortunately, I shouldn't say, are there anybody people that in the payer business in the room? Your longevity isn't their biggest concern. It should be yours, and as your employer or whatever. So I've been at Verizon 8 years. We've had 2 big insurance company moves. So when you think about that, and your records don't come from the old insurance company, by the way. So it's about trying to understand how that remote patient monitoring really makes a monetary difference for reimbursement. That's what I was trying to get to.
We are already over time, believe it or not. So I do want to close out on one question because, and there's a lot of topics we didn't get to, the impact of SD-WAN, of 5G networks. We did touch on IoT, but none of this happens without the underlying network being able to transport all this data around. As the providers of those networks, how is it that you are going to make sure that they are not only available, but reliable? Because downtime is the enemy of service in this regard. So to the panelists, we'll use this as our walk-off.
I will not say a word.
I guess I'll start as a fiber provider. Quality of network is really important for us. So we make sure that we build it ourselves always, so we know exactly what we built, so we can maintain the quality of it. And then, we want to make sure that we're nimble enough for these hospitals, so that when they say, I want a route between here and here, we're not going to build it the way we want it. We're going to work with the hospital to figure out, okay, maybe we build it a little longer for you because it's diverse from your other route that you have from somebody else. So having that sort of entrepreneurial, very custom-made network is pretty important for our vertical there.
I would add that my conversation about the edge before I think is very important. And as the edge intensifies because of 5G, IoT, you're going to want to try to keep as much transactional activity on the edge as possible. So in terms of building resilient networks, you're going to have pockets of data centers or exchanges or meeting rooms are combined where wireline and wireless services can interconnect. And you can, buy some smart technologies like SDN, maybe even AI, NFC, NFV. You can push or keep a lot of the non-core type traffic on the edge. And I think that creates resiliency. And of course, these pockets or these gateways are then interconnected in a mesh topology, which even more promotes resilience.
Networks fail. I mean, any of us that manage networks know that there are elements that are, that you cannot control. Cars are going to crash into poles. Things are going to go down. What we've found, so AdTel runs the fiber school, and we've worked with a private carrier on deployment as they have grown their network. And what they've found is that the critical components of project management and documentation on the back end, when it comes time to repair, proper training of the project managers, proper documentation and closeout packages, that are communicated through to the NOC and the people at the NOC being able to read that information results in a 30% reduction in mean time to repair. Those are hard numbers.
Bill, last word.
Well said.
Yeah.
For sure.
We build the networks with inherent architectures that actually help, alleviate issues when they do happen. But at the end of the day, the two things. At the end of the day, it comes down to economics. If someone doesn't want to pay for that redundancy, there's no way that we're going to put that in unless we're compensated. And that's the stark reality. We're dealing with investors, whether private equity or not, that want to see a return on their money. So that's one aspect of it that's challenging. If you're a smaller entity, if you're a larger entity, you pay for it because you understand the requirement, right, and the impact if it doesn't happen. The second aspect is once you get to the real edge, which is at the consumer level, is a broadband connection that you have, whether it's wireless or wireline into your home or your office. Essentially, that is inherently not redundant. at the end of the day, right? So you have to think about that impact when it comes down to that individual user. Wireless is probably better because you can, their networks tend to be a little more resilient than, let's say, your typical cable operator or someone similar to that drives fiber or coax into a home. But that's a single point of failure that you cannot avoid, unless you also have the wireless backup. So it kind of works itself. But I go back to, as a service provider, it comes down to economics. We can provide the best service in the world, but somebody has to pay for it. We're not going to do it for free because we have investors.
Well, I want to thank everyone for attending today's roundtable. I want to thank our panelists, Nancy Green, Drew Mullen, Cliff Kane, Phil Alvarez, and Brian Prophet. Great conversation. And I don't want to be cliche and wishing everybody good health.